talk, we're going to be talking about dopaminergic pathways, but I also want to go over other pathways because we have other pathways that are also implicated in schizophrenia, other neurotransmitter systems, dopamine being one of them. So the first thing we'll talk about is these neurotransmitter systems involved in schizophrenia. And these are all somewhat hypothetical, but the reason why we have these systems is basically from substance of abuse. So you can kind of think of substance of abuse to remember these. So for example, one would be dopamine. And we think of this because of methamphetamine, cocaine, and really any stimulant could cause this. And this is due to increased dopamine. So we know that if people use too much meth, too much cocaine, they're going to lose contact with reality, and that's going to result in psychosis, which could be some relation to schizophrenia. We know serotonin is also implicated. And we know serotonin is implicated because of drugs of abuse like Ecstasy, or that's not the scientific name, NMDA is really the scientific name. And this particularly affects the serotonergic 5-HT, which is just serotonin, 2A system, and it would be an agonist on that system. And actually we think that this is also implicated in dopamine, that when you stimulate 5-HT2A, then you increase dopamine in other parts of the brain, so there might be a common pathway involved in this. The third neurotransmitter system is going to be glutamate. And this is kind of a point of experimental research at this point. We have a bunch of things involved in the glutamate receptor system. One is that NMDA receptor. Another is the AMPA receptor. The NMDA receptor utilizes oftentimes glycine or serine, so these could possibly be involved. It also is involved in calcium. And glutamate is pretty much everywhere in the brain, so these would all be potential targets. Each of these would be potential targets for that glutaminergic pathway. Of course, this affects dopamine as well. So these are some other pathways that might be implicated in psychosis, but what we're going to focus on now specifically is that dopaminergic pathway. I just wanted to put it in perspective. So dopamine, dopaminergic pathways. So all dopamine is basically made in two parts of the brain, the ventral tegmental area and then the substantia nigra pars compacta. And then of course from these regions, this is where dopamine is produced. And then from these regions, the dopamine will then go all throughout the rest of the brain. It's probably easiest to kind of see this in picture form. This is going to be my best version of a brain. I'm not an amazing artist. I think we'll all be able to agree with that after you see this. So let's say this is the front of the brain, or anterior. This is posterior, or the back of the brain, and then this is the brain stem right here. So basically we have these projections that start in the ventral tegmental area in the brainstem, and they go to the interior of the brain, or they go to kind of the cortical regions, or they stay between the hypothalamus and the pituitary. And these will be our regions that we're going to be looking at. So I'm going to number these. And we have one more brain region, and we'll go over that as well. So number one would be, let's say, the Mesolimbic cortical pathway. And this is dopamine from the meso, the middle of the brain, into the cortex. Dopamine in cortex. And essentially this is involved in all the things that the front of your brain is involved in: decision making, higher order thinking. And you can test this area of the brain using like Trails tests and things like that. In schizophrenia, they actually already have a deficiency, or in psychosis in general, there's decreased dopamine in this area. Which actually leads to the negative symptoms of schizophrenia: the anhedonia, the lack of decision making, and the avolition. So it's leading to all of these symptoms. The next would be the mesolimbic. So this is number 2 here. Mesolimbic is dopamine in basically the emotion centers of the brain, the limbic system. In schizophrenia, this dopamine is high. And this is going to lead to all of the positive symptoms of psychosis: the delusions, the hallucinations, some of the disorganized, maybe even behavior, is all going to be these positive symptoms. The third pathway is the nigrostriatal. So this is dopamine in substantia nigra going to the basal ganglia, which really functions in movement. And in general, we'll just say dopamine can be involved in increasing movement or decreasing movement, depending on which receptor it's working on, the D1, D2. But in general, we'll just say it functions to increase movement. And in schizophrenia, this should be normal, right? We don't expect any decrease in dopamine in this region of the brain. And then the last region will be tubero-infundibular. Again, the where these are located is based on the naming. Tubero is the hypothalamus. It's a specific region in the hypothalamus. Infundibular is the infundibular stalk of the pituitary. And so this is the connection between the hypothalamus and the, in this case, the anterior pituitary, because it's going to release prolactin. What is the use of dopamine in the prolactin pathway? Well, in the prolactin pathway, dopamine will actually inhibit prolactin release, which then, of course, prevents, so dopamine prevents milk production. And in schizophrenia, in general, this is about normal. They don't have any increase of dopamine or decrease in dopamine in this pathway. If we turn back to our very rough sketch of the brain, this fourth pathway is going to kind of be around 3 or 4 here. Again, let's just say this is a really rough sketch. You can look this up if you want, but we'll just say it's in this pituitary region. And this is, kind of near this 3-4 is kind of near the basal ganglia region, although the basal ganglia is technically kind of more around this region, but we'll just say that's where the parts are going. So then the question is how are our antipsychotics going to affect each of these dopaminergic pathways? And this is then about EPS. EPS, we're going to talk about 4 symptoms or causes of EPS when we block dopamine. And this is because the typical antipsychotics, meaning like Haldol, block dopamine. But this can happen with any antipsychotic, either the typical or atypicals, because they're all going to affect dopamine in some way. And it's really the dopaminergic balance that's being affected, and that's the problem. And really all our antipsychotics can do is block dopamine. So then you can see how dopamine is involved in each of these pathways, and then we can see what's going to happen in each of these pathways when we block dopamine. So for example, in the mesocortical system, we're going to block dopamine. We already have a deficiency in dopamine in schizophrenia, so this will actually make negative symptoms worse. Worse cognition, more anhedonia, more avolition, all of that stuff. The mesolimbic system, we're going to block dopamine. In schizophrenia, this will make it better, or in psychosis, it'll make it better. I'm just using these interchangeably for now. You can look at another video if you want to know the difference between those two things. But the dopamine will be less, so you'll have, in mesolimbic, you're going to decrease it, so you have less positive symptoms, which is the primary effect. So you have less delusions, less hallucinations. In these two other systems, the nigrostriatal, we're going to be blocking dopamine, and so this is going to change our movement. And this is really the whole thing that EPS is caused by. It's due to the block of dopamine in this system in particular, and we're going to get four results from that. And then the tubular infundibular, we're going to block dopamine, which could increase prolactin, which in women could increase milk production. The other effect of prolactin that actually is the biggest long-term effect is that it's going to be causing osteoporosis. So it's going to affect bones because prolactin and estrogen can kind of run contradictory to each other. So really what we're focusing on EPS is this system here. This is where all our EPS systems, symptoms come from because we're blocking dopamine. And we have 4 ligands. So let's put all of those on one page. First will be dystonia. Next, after dystonia, we will have Parkinsonism. Third, we'll have Acathesia. We'll rewrite that. And then last, we will have Tardive Dyskinesia. Now, really technically, only 2 of these are EPS. And really only technically it's these, because these are the basal ganglia. Akathisia is not technically EPS. The mechanism of action for this is actually unknown. It's one of my favorite things to remember. If someone asks you what causes akathisia and you say, I don't know, you actually have the right answer. So that's always nice when that happens. The symptoms of akathisia, since we're on that right now, is like an inner sense of restlessness, and it's actually a sensation. When I just recently taught this to students, a student said, is it kind of like restless leg syndrome? Because restless leg syndrome has a sensation involved with it. And I initially said no, but then when I thought about it more and we were kind of talking about it, I thought, you know, it is similar because restless leg syndrome kind of has that sensation in the legs and maybe a crawling in the legs, and movement makes it better. And in akathisia, it's a similar sort of sensation. It is like a physical sensation that you're being driven by a motor, that you have to move, and then movement is going to make that sensation actually better. And you're just going to ask patients about this, and you'll be able to see. And if the sensation is getting better due to movement, then that is most likely akathisia. And if it happens kind of immediately when you start the medication, or the medication is increasing and you're blocking dopamine, akathisia could be involved, although we don't know why it's necessarily involved. The treatment of akathisia is important for the student to know just because it is a little more unusual compared to other treatments. And the treatment is propranolol or benzodiazepines. Now, in real life, the treatment is really just to decrease the medication or go up more slowly. One medication that's very much associated with akathisia is aripiprazole or Abilify, although any medication can cause it. And in the case of aripiprazole, that's why you want to start it at around 2 milligrams and then go up really slowly, because this akathisia can really start very early. So, but the treatment is kind of unusual, so that's why we include it. Dystonia, this is very, I want to say very common, but it commonly occurs at the beginning. It's not extremely common, but it's not uncommon. It's typically acute. Now, you can have tardive. Tardive just means slow onset. So you can have tardive dystonia, you can have tardive akathisia, but it's more typical that the dystonia is acute and the onset is within the first couple days. You really don't see it beyond 5 days. And usually the symptoms are painful cramping, in the face or the jaw or the eyes. And we have different names for the eyes, right? Like oculogyric crisis, but it's just this cramping, or torticollis, a cramping of the sternocleidomastoid muscle, or in the masseter muscles. And the mechanism of action of this is an imbalance in the dopaminergic system in the basal ganglia. And it's the imbalance of dopamine with another neurotransmitter. Do you know what the other neurotransmitter in the basal ganglia that's involved in movement is? Dopamine and another neurotransmitter are kind of on a seesaw in relation to each other. And it's an imbalance of dopamine and acetylcholine in this system. So essentially, in a normal system, we have a seesaw, and we have dopamine on one side, and we have acetylcholine on the other side, and they're equal. This is normal. But with an antipsychotic use, what do we have? We have now dopamine being pushed down. And so then it looks, there's a relative increase, you could say, of acetylcholine. That this is going to look higher, and this is with typical antipsychotic now. So now it looks like we have decreased dopamine, so then we have a relative increase in acetylcholine. And this is what's causing both the dystonia as well as the Parkinsonism, this kind of seesaw effect in the basal ganglia. So what can we do? Well, you can already tell one way you can get rid of this is just by increasing the dopamine to restore that. The other way we can do it is by pushing down the acetylcholine. So treatment would be to decrease acetylcholine using something like benztropine with benztropine, or Artane is an older medicine. Another name for benztropine is also cogentin. And we typically start this at 0.5 milligrams twice a day as needed. It's not good to decrease the acetylcholine in the brain if you don't have to, because acetylcholine does a lot of other important things, right? And of course, you're not just decreasing it in the brain, you're decreasing it in the gut. So you're going to get, if you decrease the acetylcholine everywhere, you're going to get a dry mouth, you're going to get a dry throat, you're going to have difficulty swallowing, you're going to have tummy problems, right? You're going to have constipation, that's probably the biggest, dry eyes. It's just not super fun. So you don't want to use this medication unless you have to. You also don't want to use it long term if you don't have to. Like we said, dystonia only really happens in the first couple days. It really isn't very unlikely going to happen after that, after about the first week. So there's no reason to use this medication in general for more than a week or two, even if you're scheduling it. Some doctors will schedule it. This isn't unreasonable. The reason why they do it is because they've had patients that have tried Haldol or risperidone, which are the most typical offenders that cause dystonia. And because of that, these patients got dystonia, and they will never ever try Haldol again, because it's that medicine that caused the most painful experience of their life. And so in order to avoid that, you either start those medications at low doses, or you start them on both Haldol and benztropine to prevent that. And sometimes this works. I mean, it really will work. But you just don't want them to be on the benztropine long term because they don't have to be. Because now you're going to be dealing with more side effects. Notice I wrote Parkinsonism rather than Parkinson's disease. So Parkinson's disease is a specific subset of Parkinsonism. So Parkinsonism is the umbrella term. It's anything that causes Parkinson-like symptoms. And what are Parkinson-like symptoms? Well, it's the same as Parkinson's disease. It's trap findings. That's how you remember it with the mnemonic. And TRAP stands for tremor, rigidity, akinesia, or postural instability. The tremor is usually in Parkinson's disease, which is, let me define that. So Parkinson's disease is death of neurons in the substantia nigra pars compacta, right? And you typically don't have any symptoms until like 70% of those neurons are dead. In Parkinsonism, we're not killing the neurons in the substantia nigra pars compacta. We're just blocking dopamine, right? We're just preventing that dopamine from interacting with the receptor. The Haldol is preventing that binding. So we're causing the same sort of symptoms, but it's not the same pathophysiologic process. It's just due to blockage of dopamine everywhere. The tremor then in Parkinson's disease is a little different. Usually Parkinson's disease is unilateral because you have slow death of the neuron. So you have an insidious onset of these symptoms that gradually progresses. When you're causing Parkinsonism due to medications, you have an acute onset of those symptoms everywhere. So you'll have bilateral resting tremor in the hands, maybe even bilateral resting tremor in both legs at the same time. And it's a resting tremor, so it's not going to happen when you're doing the finger to nose test or anything like that. It's just when they're sitting still. The rigidity is a cog-wheeling rigidity, which is kind of like a ratchet on a wrench, not like a song or a club. That's a different sort of ratchet. But it's a ratchet on a wrench like that just goes around like this, and you can test that by trying to move the wrist, or you can try to test it by moving the elbow, or some people will try to move all the joints at once, and it will literally kind of click as if it was a clock, and so it'll kind of catch, and a joint won't be able to move in a smooth motion. Of course, you want to make sure the patient's relaxed, because that'll also prevent the patient from moving smoothly. Akinesia, they just don't move very quickly. Another term would be bradykinesia. Akinesia is no movement, bradykinesia is slow movement, so they're not going to move quickly. And then postural instability, they have the stooped posture, shuffling steps, and just doesn't look steady, the multi-point turns, so they're going to have all of these. Parkinson's disease and Parkinsonism are still a clinical diagnosis, so there's no test that you're going to do. And I think it's usually 2 of these findings, definitely 3. I'd have to look up the criteria specifically, but it's definitely if you have 3 of these, you're going to be meeting diagnosis. So symptoms and diagnosis are essentially the same here. Both are going to be trap findings. And then the treatment is going to be the same. Again, this is really true EPS. It's because of this imbalance between dopamine and acetylcholine. And so what we're going to do again is just add benztropine. Alternatively, you could switch to an agent that blocks dopamine less. That's the whole purpose of Abilify or aripiprazole, is that it doesn't block dopamine as much. Or you could lower your dopaminergic agent if their symptoms are under control. Tardive dyskinesia, this mechanism of action is very different from the others. Let me move to a different page so we can kind of think about this. So in a normal brain that's not under any decrease or blockage of dopamine, you have a neuron, and this neuron is releasing dopamine. And then you have another neuron, and it is receiving that dopamine, right? And it's getting a signal, and it's sending that signal down. Now, if we're blocking this, though, so this dopamine now can't bind. We're not really blocking the dopamine, but we're blocking the binding. this neuron right here is going to go, what's up? Where's the dopamine? And it's going to go on a hunt, and it's going to make tons of receptors to look for dopamine. So it's going to upregulate the receptors, and not only will it upregulate the receptors, but the receptors will also be hypersensitive to dopamine. So that if and when dopamine binds, because Haldol isn't always going to be on this receptor, Haldol will sometimes be off, sometimes the dopamine will be on, so that if the dopamine goes on, this receptor now will, and this nerve will fire like crazy and will basically be on overdrive. So even though we're blocking dopamine, that blockage of dopamine tells the body to say, hey, I want to be able to find dopamine. It's going to try to find dopamine everywhere with the receptors. You'll get more receptors, and they're also going to be more sensitive to dopamine, and so they're going to fire like crazy. But they're only going to fire like crazy kind of intermittently. Still, this results in the symptoms. So the mechanism of action is due to increase receptor density and sensitivity for dopamine. So that's why it is causing this here. The symptoms, if you ever, well, we'll just go to treatment actually. So the treatment is a VMAT inhibitor. So remember, dopamine is packaged at the terminal bouton into vesicles. That vesicle is then caught by like a snare protein, and then that snare protein is going to launch the vesicle out, and then the dopamine is going to be released. So here what we have is we have hypersensitization to dopamine. We can't change that by blocking it, but we can change it by preventing the release of dopamine, which then means less dopamine interacting at the receptor site. And two medications, I'm spelling this wrong, benzene, and then valbenazine are two medications. Deuterobenazine and valbenazine are two medications that are VMAT inhibitors that prevent this. And the reason why I went over this first when I was talking about symptoms is because actually valbenazine, which is brand name Ingrezza, has some pretty good videos on this. If you go on their website, you would just type in Ingrezza, look up Ingrezza, and you'll see some of the symptoms, but essentially it's increased movement, chorionic movement, which is dance-like movement, of like the usually the lips or the tongue. So there's some snacking or gum chewing that can occur in this case. And the treatment on the test is a VMAT inhibitor. In real life, this really isn't solving the problem of this receptor upregulation system. So in real life, what you have to do is you have to decrease the dopamine blocking. And then if you decrease the dopamine blocking, then more dopamine will come in. That dopamine will bombard the receptors. The receptors will go, oh my gosh, I have so much dopamine now. This will tell the neuron, you have too much dopamine, get rid of the receptors. And then the receptors will downregulate and desensitize again. And so what you have to tell the patient is, we're going to get rid of this medicine, we're going to get rid of Haldol, we're going to get rid of risperidone. And what's going to happen is your symptoms will actually get worse. You're going to have more movements, but then your body is going to get used to that, and then the symptoms will get better. And that's why the pathophysiology of tardive is so different and why the treatment is very different. And then you're going to try to choose a medication with the least probability of tardive, which is clozapine. So now you're looking at that medication. You could also try, if they're on other medications, you could try to retitrate a different medicine, but I probably wouldn't start them on the same medication that caused the tardive. So this completes our discussion on EPS. You saw that we had to review the dopaminergic system first. And before that, we even reviewed some other neurotransmitter systems that are possibly involved in psychosis: serotonin, glutamate, dopamine. These are all important neurotransmitter systems. Serotonin, another thing that's actually involved in that is LSD. So LSD will also cause, visual hallucinations, and actually it's the serotonergic system that's being changed in Parkinson's disease as well, and Parkinson hallucinosis. It's that 5-HT2A system. So it's involved in some of these other systems as well. But then we focused particularly on the dopaminergic system, the mesocortical pathway, the mesolimbic pathway, the nigrostriatal pathway, and the tuberoinfundibulary pathway. And then we looked at the four symptoms that can happen, or disorders, you could say, that can happen when we block dopamine throughout the whole brain, and that is dystonia, Parkinsonism, akathisia, and tardive dyskinesia. We went over the pathophysiology of each, the symptoms of each, and the treatment of each. Thank you so much.